Morning, everybody.
Good morning.
Dr. Balaji, looks like maybe people are still joining. Do we want to wait one more minute, or would you like me to get going? How
Think,
would you like me to handle this?
yeah, we can give them another minute and get started on it. Thank you.
Excellent.
Thank you.
Can everybody see my slides, by the way?
Yeah, we're able to.
Yes.
Yeah.
Excellent. Okay, I'm going to get started. So, good morning, everyone. As you know, my name is Thomas Metzner. I'm PGY2 here at UF Jax, and I'll be giving the Grand Rounds talk this morning. And the topic for this morning is one that is very near and dear to my heart, that being localized renal cell carcinoma. And I chose to just focus on localized RCC or localized kidney cancer because kidney cancer itself is a broad topic. And in the sake of time, I thought I would hone in on just a localized aspect today. And so let's go ahead and get started. First of all, a little housekeeping. In terms of disclosures, I have none. So here's our agenda for the morning. So we're going to discuss the pathophysiology of renal cell carcinoma. We'll discuss some RCC demographics, as well as the history of RCC surgical management. Then we'll discuss treatment paradigms, as well as points of clinical consideration for taking care of the patient with a localized kidney tumor. We'll have a summary, and then at the end, hopefully, if we have time, we'll have a little Q&A session. And so first, I want to discuss why I care so much about kidney cancer. So this gentleman right here, this is Larry, upstanding community citizen, attorney in the Bay Area, very prominent guy, did a lot of charity work, very good man. And he was the first kidney cancer patient I ever encountered. He was diagnosed with renal cell carcinoma in April of 2010. He woke up one morning, had an episode of gross hematuria, went to the hospital, received a CT scan, and was notified that in addition to a large renal mass, he also had evidence of metastatic disease involving some bone and some liver. And he subsequently began his treatment journey for kidney cancer. And Larry was my uncle. So this is him and I. Like I said, this was in 2010, 2011, just after I had graduated from college. And this picture on the left is him shortly before his diagnosis. And this picture on the right is of him as he was being actively treated. And anybody who knows the course of kidney cancer and is familiar with early treatment paradigms in the 2010-2011 period can recognize some of the hallmark characteristics of a patient on tyrosine kinase inhibitors. So there's some graying of the hair, excessive graying of the hair, cachexia, and Larry had also had a spinal fusion at this point. He had a cytoreductive nephrectomy, and unfortunately, Larry died in December 2011, roughly 18 months or so after his initial diagnosis, which is in keeping with the literature at the time of a median survival rate for a patient with metastatic kidney cancer. And what I didn't know at the time was that Larry's treatment and his eventual death from this disease would literally alter the course of my life. And I began studying kidney cancer shortly after he died. And that was how I was introduced to urology. And then from there, I continued to pursue my interest in urology and became a urology resident. So kidney cancer is very personal to me and has literally shaped the journey of my life. So that takes us to RCC pathophysiology. What are we talking about here? So renal cell carcinoma is a tumor that specifically arises from the renal parenchyma. It originates in the cells that compose the tubules of the nephrons. And RCC has approximately 20 distinct histologic subtypes. And I think this is probably being updated on a daily basis because there have been a number of discoveries in recent years. But really,
it's a different world, isn't it?
But 3 of them are most clinically significant for us.
Good.
Hey, do you guys mind muting if
What are you working on here?
At the other side.
Okay. Anyway, 3 significant, clinically significant subtypes.
Thank you so much for your
those being clear cell, papillary, and chromophobe RCC. And when we break kidney cancer down by those subtypes, approximately 75 to 80% of kidney tumors that are diagnosed are clear cell, while 10 to 15% are papillary, and approximately 5% are chromophobe. Clear cell tends to be the more aggressive subtype. Papillary RCCs can also be pretty aggressive, while chromophobe RCC actually has more of an indolent course. And the growth of these tumors is precipitated by metabolic derangements. Major ones we'll discuss here in just a minute. It's the most common malignancy of the kidney, and it's also associated with some hereditary syndromes. So clear cell RCC is associated with von Hippel-Lindau syndrome. Papillary 1 RCC is associated with hereditary papillary renal cell carcinoma, which stems from a mutation in the MET gene. Chromophobe, RCC is associated with Burkitt-Dubé syndrome. And there's also a syndrome called hereditary leiomyomatosis and renal cell cancer syndrome, or HLRCC. And this is a depiction of the anatomical aspects of the kidney, of course, but then these renal tubules. And so the proximal and distal convoluted tubules is where kidney tumors tend to arise. So here is one of those aforementioned metabolic derangements.
Just a quick comment. The most recent classification of renal cancer has done away with papillary type 1 and type 2. They put everything in the papillary category because 2 reasons. The pathologists cannot call with confidence whether it's type 1 or type 2 based on histology, and it also doesn't necessarily useful in predicting outcomes. So it's all in one basket now, papillary renal cell.
Okay. Thank you, sir. I appreciate that.
Thank you, Tom.
Okay. So here is one of those aforementioned metabolic derangements in a pretty significant pathway that we should all be familiar with. So this is the HIF and VHL pathway. So VHL, or the von Hippel-Lindau protein, is a regulator of HIF-1 alpha. HIF-1 alpha stands for hypoxia-inducible factor 1A. And the HIF complex of proteins is involved in angiogenesis. Specifically, this protein subset senses hypoxia and induces upregulation of VEGF, vascular endothelial growth factor receptor, vascular endothelial growth factor, which precipitates angiogenesis. And the reason this is important is that loss of VHL is present in approximately 90% of clear cell RCCs. And so it is the key driving derangement in the most common type of kidney cancer. And because VEGF is involved in the mitogen activated protein kinase pathway, this results not only in increased angiogenesis, but also cell growth and proliferation, and dysregulation of this pathway results oftentimes in aberrant blood vessel growth. And the reason that's important for us as surgeons is that these tumors tend to be very bloody tumors, and they can have parasitic vessels and microvasculature that can ooze throughout a case when we're trying to operate on these tumors. And so understanding this pathway and why these tumors behave the way that they do is important. So here's a little bit on RCC demographics. So there were just over 81,000 new cases of renal cell carcinoma diagnosed in the US in 2024, and just over 14,000 deaths. 52,000 of those cases occurred in men, while 29,000 occurred in women. And the median age of RCC diagnosis is 65, but typically a range of for patients between the ages of 55 and 74. It has, as I mentioned, a greater incidence in men than women, approximately 2-to-1 ratio. And in the United States in 2016, it cost Americans $3.42 billion to treat this disease. Some of the risk factors associated with RCC include metabolic syndrome, also the genetic preponderances that we just talked about, smoking, exposure to toxins and chemicals. And then staging is based predominantly on size initially, and then on invasion of surrounding structures. And this figure to the right here depicts the most common cancers in men and women. And this is from the American Cancer Society 2025. And what you'll note is that kidney cancer is amongst the top 10 in both men and women. So it's a very clinically significant disease. So this is how we stage RCC. Yes,
the other thing I would highlight in that very important slide you just showed on frequency, if we really think about it, more than 40% of adult cancers are urological cancers, prostate, kidney, bladder. And so it's just truly remarkable how much of cancer burden that our field has to manage. And that's why oncology is so busy in our subspecialty. Thank you.
Indeed, sir. Thank you.
Yeah.
So this slide depicts staging for RCC. So staging has implications, of course, on surgical management, as well as understanding likelihood of recurrence and metastasis, and then survival. So stage 1 RCC is based predominantly on the size of the tumor. So tumors that are less than 7 centimeters in their greatest dimension, and they're limited to the kidney. And stage 1 RCCs have an excellent survival rate. They have a 5-year survival of 95%. And then stage 1 is also subdivided into T1A and T1B tumors. And T1A are tumors that are less than 4 centimeters, while T1B tumors are between 4 and 7 centimeters. Stage 2 RCC comprises tumors that are greater than 7 centimeters in the greatest dimension, but they're limited to the kidney. And again, these are broken down into subtypes T2B and T2A. So T2B are tumors that are between 7 and 10 centimeters, while T2B are tumors that are greater than 10 centimeters. And these also have a fairly good 5-year survival at 88%. Stage 3 kidney cancer is determined more by invasion of surrounding structures. So these tumors involve major veins, as well as the adrenal gland or tumor within Girota's fascia, but not expanding beyond it. And you can also have one regional lymph node involved with T3 tumors, and it will still be comprised of T3. And T3 is also broken down by the presence of a tumor thrombus. So a tumor thrombus in the renal vein is classified as T3A, while as a tumor in the IVC is T3B, as long as it's below the hepatics. And then a tumor thrombus above the hepatics is classified as T3C. Stage 4 kidney cancer, T4 tumors, are tumors that expand or invade beyond Girota's fascia, and they have greater than one regional lymph node involved. And I didn't mention the 5-year survival for T3, that's 59%. Stage 4 T4 tumors have a 5-year survival of 20%. This figure you'll see is from Cohen in 2005, And when I saw this figure, I really liked the figure, but I thought, okay, I should probably look at current survival metrics. And actually, this has not changed very much. There was a recent review published in JAMA this year, and they quote nearly the same 5-year survivals for these tumors. What's also important to note is how often we see each one of these tumors. So stage 1 tumors comprise the vast majority of the tumors that we see, at approximately 70% of tumors that are diagnosed. And this is a fairly recent paradigm shift in kidney cancer. We didn't see T1 tumors comprising the vast majority of tumors until really the late 90s, early 2000s. And it's mostly attributed to the increased use of imaging, that being CT scan, and findings of incidental tumors, so finding smaller tumors. Prior to that increased use of imaging, stage 1 tumors comprise about 50% of tumors. And so it's far more common for us to encounter very large tumors, more advanced disease at the time of diagnosis and consideration for surgical intervention. And then below that, you'll see stage 2, stage 3, and stage 4 tumors comprise 11, 8, and 11% of the tumors that we encounter, respectively. So before we get into discussing the management of RCC, I want to discuss a little bit about RCC history and in particular, the history of nephrectomy. So in 1871, Dr. Walcott performed the first radical nephrectomy for what we now consider to be a renal cell carcinoma. And at the time, it was called a hypernephroma. So it was a tumor of the kidney. In 1948, Mortensen described a particularly difficult left radical nephrectomy that was managed with a thoraco-abdominal incision in order to completely expose and remove this very large tumor. And it was performed in a woman who had had essentially a delay in her care because at the time she had spent 3 years in a Japanese internment camp during World War II and really hadn't had access to intervention. What's also interesting about the thoraco-abdominal incision, and in particular exposure to the retroperitoneum, is that the approach to this incision actually began on the battlefield. And so in the 1800s, this incision was adopted by battlefield surgeons in order to get exposure to the chest and the retroperitoneum. And this approach to kidney tumors was really thought to be really the way to go. And the physician who is credited for really describing a true radical nephrectomy was Dr. Robeson. And this was published in 1963 in the Journal of Urology. And he followed that up with a series of radical nephrectomies with lymph node dissections, also published in the 1960s. And he defined a radical nephrectomy as being performed through a thoraco-abdominal incision, which included division of the diaphragm, and then removal of the entire kidney, the ipsilateral adrenal gland, Gerota's fascia, and then the surgeon was also to perform a lymph node dissection for the localized nodes around the renal hilum. And this was performed for essentially all kidney tumors. So this was the standard for treating RCC. And this proceeded as the standard through the 1970s and really into the 90s. In the 1970s, Don Skinner at USC began writing extensively about the surgical management of caval thrombus and renal vein thrombus, also in treating renal cell carcinoma. And so this is a picture of the thoraco-abdominal incision, and you can see what a maximally invasive incision this would be. A very morbid operation with, I'm sure, a tremendous amount of recovery time and a high potential for complication, no doubt. But this was being approached this way because these guys were dealing with very large tumors. As I mentioned, imaging wasn't where it was now. And so these guys were encountering, no doubt, very big tumors. Then in the 1980s, this guy came along. So this is Dr. Andrew Novick, and he is the former chair at the Cleveland Clinic. And his group, as well as Scott Campbell, who's also at Cleveland Clinic, began publishing on the utility of partial nephrectomy. And this became pretty controversial. So this proceeded, he continued to write these series on patients that he was managing, predominantly small renal masses with partial nephrectomy. In 1990, Dr. Clayman performed the first laparoscopic nephrectomy. And then in 1995, Butler, who was also working with Dr. Novick and Dr. Campbell, published what has really become known as a seminal paper. And that paper showed that in a comparison of radical nephrectomy versus partial nephrectomy, they carried essentially the same 5-year survival rate in patients who underwent the respective surgeries for the management of a small renal mass, those being masses less than 4 centimeters. And this was really considered seminal and essentially changed the standard of care. It showed that partial nephrectomy was a completely viable option for treating patients with small renal masses. And then in 2004, the first series of robotic partial nephrectomy was published by Getman. And this has now become essentially the gold standard for performing a partial nephrectomy. Ideally, this would be done robotically, and when possible, we would excise just the tumor. And so here's a shout out to Dr. Novick. Unfortunately, he's no longer with us. He passed away in 2008 from lymphoma. But in his obituary, written by one of his colleagues, he was quoted as having the motto, "Never stop fighting." And it was absolutely appropriate based on what we know about Dr. Novick, because he was really a champion for changing the way that we approach these tumors. All right, so now we'll move on to discussing treatment paradigms for localized RCC. And I included this picture here because this is essentially the challenge that we are facing, is we are playing a game of sharks and minnows. So we're going to encounter a large number of small renal tumors that are essentially the minnows. The likelihood of them metastasizing or being life-threatening to the patient is likely very small. But what we're always on the lookout for are the sharks, are the things that are potentially dangerous. And all sharks start as a small fish, right? And it's our job to try to determine which patients will benefit from these treatment paradigms so that we can avoid the sharks. We want to catch the sharks early so that we can do the best for our patients. And the paradigms that we're going to discuss are surveillance, and sometimes surveillance with the use of biopsy, partial nephrectomy, IR-guided ablation, and radical nephrectomy. So we'll start with surveillance. So surveillance involves imaging of a renal mass, typically a small renal mass, to assess for growth or aggressive features. Aggressive features include things like centralized necrosis, encroachment upon major structures, the renal sinus fat, as well as the hilum, and then, as I mentioned, growth that we deem to be potentially an aggressive growth rate. The reason this is important is because on radiographic imaging alone, where it is thought that a tumor has likely characteristics of a malignant lesion, in reality, when those are operated on, approximately 20% of small renal masses are found to be benign. So it could very well be that we end up over-treating these masses if we're not careful. And so surveillance protocols typically involve imaging initially at a 3-month interval, and then a 6-month interval, and then every 6 months for up to 3 years, and assessing for that growth and the aforementioned aggressive features. Sometimes surveillance protocols also include the use of biopsy. And so good candidates for surveillance protocols tend to be patients who are frail. They may have an abundance of comorbidities. They may be older, as well as patients who have a solitary kidney, such that we're not trying to operate on that solitary kidney and run the risk of injuring it. And the ideally, also, that small renal mass would be less than 2 centimeters if we're going to put a patient on a surveillance protocol who is healthy, but it's acceptable to go up to 4 centimeters in patients who have an abundance of comorbidities. And so if we're thinking about this theme of sharks and minnows, we really have to think, well, is it safe to surveil these patients? Or is there a potential that we will miss a shark? And there's been some examination into the safety of surveillance, and it appears that for the most part, surveillance is safe. And so this is a paper from Dr. Race Barami in 2009. And this was a small cohort of patients, 32 patients randomized to surveillance versus upfront partial nephrectomy. The mean tumor size for patients in this protocol was 1.8 centimeters. And the mean surveillance duration was 15 months. And it was found that in this study, the mean growth rate of these tumors was approximately 0.5 centimeter per year. And importantly, within this cohort, there was no upstage from a T1A tumor to a T3A tumor. And the reason I think that the authors chose to utilize T3A as the comparison staging is because one of the things that we're concerned about with a small renal mass is not necessarily that it will grow to this enormous size in a year or two, but rather that it may invade, say, the renal sinus fat, and then it would be upstaged to a T3A. But along with that, what's important to keep in mind for this paper was that it didn't seem that they delineated growth to, say, a T1B or a T2A, something that may precipitate a radical nephrectomy versus what might remain amenable to partial nephrectomy or another minimally invasive approach, such as ablation that we'll talk about in a little bit. Another paper examining surveillance is this paper from Dr. Alam et al. And so this involved the DISSRM registry, which is a registry of tumors, small renal masses, that involve patients who went on to intervention versus patients that are on surveillance protocols. And so within this cohort of patients, they had just over 600 patients, 317 of which were on active surveillance protocols, while 298 were in an intervention arm. The median follow-up for these patients and their renal masses was 2.9 years. And at 5 and 7 years, there was no difference in cancer-specific survival between the two arms. The active surveillance group did have a lower overall survival, but this kind of makes sense when we think about these patients because they tended to be patients who had more comorbidities. They were patients that we would likely put on active surveillance because we are not in a rush to operate on these patients. What is important to note from this, however, is that the active surveillance group had a progression-free survival at 5 and 7 years of 76.7% and 48%, respectively. And progression in this group was defined as a growth greater than 0.5 centimeters per year, a diameter that was greater than 4 centimeters, so something that took them out of T1A and put them into a different staging category. The presence of metastasis, as well as elective crossover from the active surveillance group into the treatment group. And that's probably a reflection of some anxiety that patients experience when they are on an active surveillance protocol. And the reason it's important to keep this progression-free survival picture in mind is that if we have a patient who is fairly young, fairly healthy, then at 5 and 7 years, we can extrapolate from this that a quarter of those patients are going to progress at 5 years, while at 7 years, more than half of them are going to progress. So active surveillance protocols are really suited for patients who have the comorbidities and things like that that are likely going to make us think twice about intervening on them. In patients who have a life expectancy greater than 5 or 7 years, the likelihood of us having to do something on these tumors anyway is quite high. And so that's something to keep in mind when we're considering patients for active surveillance versus intervention. So next treatment paradigm we'll talk about is something that is often coupled with active surveillance, and that's the use of renal mass biopsy. So these are typically performed under CT or ultrasound guidance. And there's an abundance of data showing that these procedures are safe from a risk of tumor seeding standpoint. For a long time, it was thought that, well, if you violate the tumor, then you could potentially seed the skin when you perform these biopsies. And our colleagues in interventional radiology have really eliminated this with the use of access sheaths. And so now the risk of tumor seeding is approximately 1 in 10,000 biopsies. Biopsies can yield information on malignancy as well as some information on possible histology. And in a study from 2016 written by Patel et al. That featured just under 3,000 patients with over 3,000 biopsies, the successful diagnostic rate was 86%, while the risk of some complications, those being hematoma, was 5%, and the risk of severe pain as an adverse outcome was approximately 1%. So patients tolerate these procedures well, and the likelihood that we are going to acquire good diagnostic information from these procedures is quite high. So that takes us to our next approach to these tumors, which is ablation. So again, this is a procedure performed predominantly by interventional radiology. And ablation techniques typically use either radiofrequency or cold temperature to destroy a tumor. The ability to perform ablation can be limited by some anatomical factors, those being the proximity of the tumor to large vessels or the collecting system, as well as the size of the tumor. So patients are likely to benefit from ablation are patients with extensive comorbidities who wouldn't tolerate surgery very well, and typically patients who have small tumors, those being less than 3 centimeters. And in fact, the AUA guidelines say that 3 centimeters is really kind of the cutoff for considering patients for ablation. Something that might be important to the urologist to keep in mind is the potential need for biopsy with these tumors. So despite a needle being inserted into these tumors in order to perform the ablation, a tissue specimen is not always collected. And so it's not always certain what exactly these tumors are, if they're even malignant, or if they are malignant, what type of kidney cancer are we dealing with? And this can potentially be distressing to patients. And those patients are likely going to come back to the urologist for their surveillance going forward after they receive the treatment. And so requesting a biopsy from the interventional radiologist at the time of ablation may be an important thing for the urologist to keep in mind, particularly with radiology literature stating more and more now that they feel confident in saying something is malignant based on imaging findings. But we know that 20% of these small renal masses that are deemed to likely be malignant based on imaging findings are actually benign. So this is something that's important for us to keep in mind as the urologists who are going to end up seeing these patients afterwards. And in a study,
Tommy,
yes.
if I can make a comment, no, it's imperative. And it's an understanding that we have with interventional radiologists here or other places. See, they don't want to get a biopsy because it's going to maybe mess up their ability to freeze and cause bleeding. But it's imperative because, yeah, I mean, if we have a low, if you have an oncocytoma, something smaller like that, and then it's frozen, well, then follow-up isn't necessary. So it's not good to know, it's absolutely necessary to know. And it has to be clear to this group here and any other group that you deal with in the future, they have to get a biopsy because that tells us what we're dealing with. Thank you.
Thank you, Dr. Bendick. I actually feel as strongly as you do. I just was trying to understate it, I guess, to be polite. But I appreciate your clinical wisdom on this matter. And I think if we think of performing a nephrectomy and we take out a tumor and then it never goes to pathology and we see our patients and we say, well, we took it out, but we don't know what it is. How many of our patients would be satisfied with that? Not very many. And so that's, I think,
follow that patient in the future.
That's exactly right. Yes, absolutely. Absolutely. Yes. Okay. And so a little more about ablation. There is a study published in 2022 that featured nearly 14,000 patients who had undergone either partial nephrectomy or some type of ablative therapy. And what the study found was that there was no difference in metastasis or cancer-specific survival in patients where they underwent, partial nephrectomy or an ablative therapy for a small renal mass. However, what they did find was that there was a higher local recurrence in both T1A and T1B tumors. So partial nephrectomy is more likely to result in a definitive therapy, that being a therapy that does not necessitate potentially going back and resecting that tumor versus ablative therapy. But it would appear that both of them are equivocal in terms of the risk for metastasis and cancer-free survival, or cancer-specific survival, All right, so speaking of partial nephrectomy, that takes us to partial nephrectomy. And here is Dr. Novick over here on the right performing, well, I'm not sure what this operation is, but we'll just go ahead and say it's a partial nephrectomy because this was really, he was a bona fide kidney surgeon. That was kind of his deal. So hopefully this is a partial, which would be totally appropriate for this talk. And so the gold standard of surgical management of small renal masses is really the partial nephrectomy. It can be performed robotically or open, and in some places it's even performed laparoscopically. The trifecta for partial nephrectomy is a series of standards met during the operation, that being negative margin on the tumor, limited warm ischemia time, ideally less than 25 minutes, although this has been increased to less than 30 minutes in some publications. And that's in order to preserve EGFR, and then no perioperative complications. And this trifecta has now grown into a pentafecta, which involves the previous three standards, as well as a long-term maintenance of pre-op renal function, and then no recurrence of disease after the surgery is completed. And in a 2023 publication from Sharma featuring 614 patients, although we are striving for this, the literature would indicate, at least in this cohort, that is not often met. So the trifecta was met in 60% of these patients, while the pentafecta was met in only 24%. So lofty goals, but the literature would seem to indicate that they're not always achieved. In terms of ischemia time, this has been a controversial subject. Some urologists say, I don't think this really matters. Others very much live by this. And so if you take a dive through the literature, you'll kind of find mixed results. But I found a paper from Kazama et al. That was published in the British Journal of Urology in 2024, and it seemed to indicate that EGFR recovery was significantly impaired by ischemia, particularly warm ischemia that was greater than 30 minutes. So that harkens the question, well, how can we limit warm ischemia if that is an important part of surgical consideration? And there's a variety of ways that we can do that. So one of them, at least in open cases, is actually icing the kidney. So this is an example of that. This is ice that is used to surround the kidney and actually cool the kidney down before inducing ischemia and dissecting out the tumor. We could also potentially implement selective clamping. And so this is an example of a robotic nephrectomy in which segmental arteries were clamped as opposed to the main renal artery. And with the use of selective clamping, a technology that we could potentially implement is actually the use of ICG. And so where ICG comes into play is it can be administered intravenously by the anesthesia staff, and it will perfuse a perfused kidney and can be seen utilizing the robotic camera. And if we clamp the correct segmental artery that we think is feeding the area of the kidney in which the tumor is located, then we will see a dark tumor. And we can potentially use this technology to find the right vessel to clamp so that we don't have to ischematize the entire kidney. And then there are also parenchymal clamps. And so this is an example of a parenchymal clamp that is literally put around the entire kidney and used to induce ischemia to the part that contains the tumor, while the rest of the kidney remains perfused. And so this is just one example of a parenchymal clamp. And the one that I saw implemented was actually a Kaufman clamp. It was developed by Dr. Joseph Kaufman at UCLA. And it was something that was occasionally utilized on the West Coast when I was working with some urologists over there. So interesting approach to minimizing this ischemia. All right, and so this takes us to radical nephrectomy.
I'm sorry for interrupting you again.
Yes, sir.
It's a good paper from really Mayo Clinic, Rochester, that every minute counts is the title of the paper. And so, yeah, it's not less than 30 or less than 25. It's like any minute is important. And what we tend to do is after we do you'll see this, you probably have, that we usually unclamp after we put the V-locks in to make that first closure of the kidney and then we usually unclamp at that point because we have good hemostasis, and that reduces our warm ischemia time. Yeah, in the old days too, we used to fill the whole abdomen up with ice, and it was it was a good time. Thanks.
Thank you, Dr. Bannick. And that illustrates another potential approach to minimizing the ischemia is we can actually unclamp early. So we can get enough hemostasis in the renorrhea such that we feel confident in taking the clamp off, or we can test the clamp off of the artery and seeing if we have adequate hemostasis to complete the renorrhea, knowing that clamp can go back on if needed. So that is another approach to minimizing ischemia. Thank you, sir. All right, so now we arrive at where we started, which is radical nephrectomy. And this remains a mainstay of kidney cancer treatment, particularly for large renal masses, as well as masses that involve central aspects of the kidney, i.e. they're close to the renal hilum, they may be involved extensively in the collecting system, and in order to perform a good cancer operation, because it's important to remember that first and foremost, a partial nephrectomy is a cancer operation, which means we are trying to remove all of the disease and render a patient no evidence of disease. And if that can't be performed safely, then we really need to start thinking about radical nephrectomy. And so this remains a mainstay of treating these tumors. These can be done laparoscopically, robotically, or open. And this often depends on the size and the complexity of the tumor. And it may simultaneously involve removal of a renal vein thrombus or an IVC cable thrombus. And remember, these tumors are highly vascularized tumors with an aberrant blood supply featuring parasitic vessels, and so they will often ooze and bleed extensively throughout the case, even with the slightest manipulation. And here are some radiographic images. Probably goes without saying, these are the sharks, folks. So here's a very large left renal mass. I think it was approximately 10 to 12 centimeters in the paper that was featured. And you can see some of these areas of necrosis, kind of this multilobulated sort of heterogeneous mass. And then these dark areas are areas of necrosis indicating that the that the tumor is growing so quickly that it's outgrowing its own blood supply. And here's an example of a right kidney tumor that is essentially obliterated the normal kidney, and you see this area of necrosis here. And then this is a cable thrombus that is extending above the hepatics but below the diaphragm. So speaking of thrombi, it's important to know how these thrombi are staged, and this is the staging system. So a tumor thrombus that is limited to the renal vein is a level 0 thrombus, and these are typically amenable to radical nephrectomy. A level 1 thrombus is a tumor thrombus that extends into the IVC, but is less than 2 centimeters above the renal vein. Again, managed with typically just radical nephrectomy and potentially opening of the IVC. A level 2 thrombus extends into the IVC, but is greater than 2 centimeters above the renal vein, but below the hepatic veins. And this can involve blocking of the IVC underneath the hepatic vein and opening the cava. And a level 3 thrombus is a tumor thrombus that extends above the hepatic veins but below the diaphragm and this requires mobilization of the liver and potentially vena-venous bypass. And then a level 4 thrombus is a thrombus that extends above the diaphragm, and this is going to involve the patient being on intraoperative extracorporeal circulation, i.e. cardiac bypass, because it is going to likely involve opening the right atrium and excising the tumor from the heart. And this is a depiction of those anatomical thrombi levels, and you can see the various extension of the thrombus. And then this figure down here is an image from a robotic radical nephrectomy that had a renal vein thrombus. And what the surgeon has done here is position the stapler beyond the renal vein, essentially right where it meets the cava. And despite this being fairly aggressive tumor with this thrombus, it's still amenable potentially to robotic nephrectomy without opening the cava if the stapler can be positioned beyond the thrombus in the renal vein. And this is something that is rather an advantage of the robotic approach to these tumors for these types of situations. And this is a depiction of how we may potentially handle a thrombus. And so what is, at least in the cava, and so what is critical is acquiring control of the vena cava from all of its inflow sites surrounding the tumor. So typically involves clamping of the contralateral renal vein, as well as clamping above and below the thrombus, and then opening the cava and removing the tumor along with the kidney en bloc after control of the renal pedicle. And this can be performed in a number of ways. This depiction on the right is utilizing bulldog clamps, but the use of Ramel tourniquets can also be utilized, along with this looks like a Satinsky clamp that's positioned above the thrombus on the superior aspect of the IVC. And you'll see this dilated left renal vein, and then these Ramels are temporarily occluding of course, the right renal vein and the portion of the IVC that is below the thrombus. So in summary, renal cell carcinoma or kidney cancer represents a variety of histologies. RCC is in the top 10 cancers in both men and women in the US. Based on that figure that I showed earlier, demonstrating those top 10 cancers in men and women, it's the second most lethal urologic cancer, second to bladder cancer. Localized disease features a mix of fairly indolent tumors and highly aggressive tumors that are high risk for malignancy. And we need to know how to handle both, and we need to do our best to recognize the potential for a shark. Treatment of localized RCC must be based on individual tumor characteristics with consideration of patient health and risk factors. And then irrespective of treatment modality, the urologist really forms the cornerstone of care for the patient with a renal mass. Even if they undergo ablation with IR, we are going to manage their surveillance. We are going to be the ones that discuss the histology of their tumor and the predicted course, and we are going to be the ones who are going to be there helping to steer their care, even in the times where their cancer recurs, unfortunately. And I started this talk with a sad story of my personal connection with kidney cancer, but I want to finish it with a happy story. So this is my dad, and he is also a kidney cancer patient. So he was diagnosed with a small renal mass during my intern year, and he underwent partial nephrectomy robotically, had a good outcome, and the histology was found to be a grade 3 clear cell, negative margins, and he's doing well. And this is him and I at the Rose Bowl when Stanford absolutely smoked Iowa. It was a great game. One of my happiest memories of my dad, and he's doing well. These are my references, and I will conclude with a thank you for your attention, and also just a personal thank you to the people on this call that care for kidney cancer patients, are teaching us residents how to operate on patients with kidney cancer. My co-residents who have taught me even the simplest things like placing ports and a nephrectomy. I thank you for your tutelage and the opportunity to continue to work in this field. For somebody who has had their life affected by this disease, who has lost a loved one and seen those family members suffer, it is tremendous to think of the work that people are doing. And so I just want to thank everyone on this call that is involved in that realm. And in the immortal words of Dr. Novick, never stop fighting. And I am happy to take any questions.
Thank you, Tommy. That's a great talk. And, any questions for Tommy? Comments? So, Tommy, we looked at the SEER data. Now I'm dating back now over 20 years ago. And our initial hypothesis was that because CAT scan came into vogue in the 1980s, over the next 2 decades, the number of metastatic disease would decrease, or at least advanced would decrease, and the localized kidney cancer would increase. And what we noticed was the localized kidney cancer did decrease, but the advanced and metastatic disease did not decrease. In fact, it continued to increase. So the study period, I think this was between 1973 to 2000, and the inflection point was somewhere around in the mid 80s when the CAT scan was increasingly available, and you could see the inflection point. The localized went up, but there was a steady increase in advanced and metastatic kidney cancer. That told us something very fundamental, that although we call them all kidney cancers and even use histological identities, biologically we may be dealing with different entities. And in fact, even today, at one point before, it's generally thought almost 20-25% of patients with kidney cancer are actually present with metastatic disease. And currently, I don't think that's too far off the mark. We still see a large proportion of kidney cancer patients do present with metastatic disease. So, biologically they're different, and that has led to some of the more recent developments in the classification, where we are now using molecular classification for kidney cancer. So we are identifying kidney cancers such as SDH mutated. In addition to the classic syndromes, you talked about the HLRCC, which is the folliculin gene, or the Burdock-Dubé, which is the fumarate hydratase. And then we have the more recent molecular classification of TFE translocation tumors. So it is really coming of age that we are dealing with different types of kidney cancers from a molecular and a point of view, and the pathology is dissecting these in greater detail. So this is a evolving field, and with all the modern treatments that are becoming available, and most recently the HIP2 alpha inhibitor based on the biology you showed us on the VHL. These are remarkable progress, but I agree with you, there's still a long way to go. And appreciate you providing some clarity on management of these localized kidney cancers.
Those are all really great points, and I thank you for bringing that up, Dr. Balaji. I too am familiar with the SEER data and the increased preponderance of the small renal mass localized disease, and yet, as you mentioned, we didn't see a decrease in metastatic RCC and more advanced tumors, which would indicate that finding these tumors early is not necessarily of benefit. And to kind of piggyback on what you were saying, as I was doing a dive through the literature and I was taking a look at, for instance, some of the surveillance data, what is discussed throughout the literature is that these tumors often do not display linear growth. that is, even though we say that there is an average growth rate of 0.5 centimeters per year, in reality, more aggressive tumors will diverge from that quite rapidly, and they may be cruising along at 0.5 centimeters a year, and then will demonstrate tremendous growth. And I think that that is an indicator of exactly what you're talking about, which is something is happening at the molecular level that is influencing the tumor biology and precipitating more of an aggressive phenotype. And it's going to be an onus upon us, the surgeons who treat these tumors, to try to sort that out, try to figure those things out, and try to predict those events rather than just simply finding these tumors early. And I think that some of the things that we've been talking about, such as the use of cell-free DNA, and really understanding what these tumors are expressing, not just the genetic aberrations like we discussed on Friday in our basic sciences meeting, but what are these tumors actually expressing at the molecular level with their proteins? What are driving these tumors is really going to be the critical next great leap in kidney cancer. And we've already made tremendous leaps, not only in our surgical management, but also systemic therapy for patients with metastatic RCC. The use of checkpoint inhibitors has increased the 5-year survival rate for those patients. And so I think the next frontier is trying to, once again, sort out the sharks versus the minnows and what makes a shark when it, of course, starts out as a small renal mass. They all start out as a small renal mass.
Yeah.
And so your point is well taken.
You know what would be very exciting, Tommy? I'm really, really excited and also very hopeful that, prostate, kidney biopsies are debated because I think we are limiting ourselves to looking at the histology. That by itself may or may not influence management as much. But if we have those tissues and we can look at genetic sequencing, and then if we can use that sequence data to answer the question, these are nonlinear growth, could we, based on the current information, predict there's going to be, say, 5 years from now, this tumor is going to grow faster, and therefore we have to react now? Whereas certain genetic signatures very rarely grow. And I think this is Rainier's contribution to our program, where he has looked at genetic data and looked at divergence. And of course, these are post-treatment follow-up and so on. But we could use some form of idea, the same concept, to look at genetics of renal masses and see whether we can predict divergence at a future date or lack of divergence. So, there are a lot of information out there that we can creatively think about and see how we can apply it. And we'll continue to have this discussion. So.
Absolutely. It's an exciting time, as always, to be studying these tumors and just trying to make progress. And the fight continues.
Okay. Any other questions or comments? Okay, if none else, we'll stop here, and all of you guys have a great week. Thank you. And thank you, Tommy.
Thanks, everybody.
Hey, Tommy, when you have a chance, just forward the slides to Melanie so that she can forward it to the rest of the team. This is
sure.
very valuable.
Will do.
Thank you, Tommy.
Thank you, sir.
Thank you. Bye-bye.